Our next section is myocardial and pericardial diseases. Now, myocardial diseases means cardiomyopathies, and cardiomyopathies can be either hypertrophic. Now, hypertrophic means you have a high ejection fraction. Hypertrophic cardiomyopathy means that you have a high ejection fraction. Hypertrophic cardiomyopathy means that you have a high ejection fraction. You can contract, but you can't relax. Dilated means you have a low ejection fraction. You can relax, but you can't contract. This can contract, but can't relax. This can relax, but can't contract. Restrictive can't do anything. It just lies there. Restrictive cardiomyopathy can't do anything. Just doesn't fill at all. Hypertrophic cardiomyopathy, the most common cause of which is hypertension. Hypertrophic obstructive cardiomyopathy, that's a different story. Hypertrophic obstructive cardiomyopathy means that you can present with syncope and sudden death if it's obstructive cardiomyopathy. Your mission about restrictive cardiomyopathy is just to know what things freeze or hold the ventricle in stasis, non-moving. Now, dilated cardiomyopathy. Decreased contractility. That's the same thing as saying low ejection fraction. It's decreased contractility, low ejection fraction. Dilated cardiomyopathy is usually the left, but can be both. If the left dilates, it dilates the right later on. Now, dilated cardiomyopathy is the most common indication for a heart transplant, but the most common reason for it is ischemia. Ischemia causing a person to have dilated cardiomyopathy. Why does it dilate? Ischemia. Why does it dilate? I don't know. Ischemia. Alcohol does it as well. So when you have a person who's given birth and they have peripartum cardiomyopathy, we don't know what causes it. We know a small number of women make antigens that the antibodies attack their heart and you get a dilated cardiomyopathy. Why is it? I don't know. It's just the way it is. Now, drugs can cause a dilated cardiomyopathy. But the other thing is, whether it's Chagas disease or alcohol or adriamycin, or whether you're a cobalt-inducing adriamycin junkie who's just given birth and you're an alcoholic baby, the answer is all the same. I'm short of breath, paroxysmal dyspnea, echocardiogram, give me an ACE inhibitor and a beta blocker. What's the only difference between a dilated cardiomyopathy that's idiopathic and an ischemic one? Aspirin to fix the coronaries. Which is better for you, alcoholic cardiomyopathy or ischemic? Ischemic. Because I could take you to the operating room and fix your ischemia in 4 hours, but I can't fix your alcoholism. I can bypass your coronaries without your consent, but I can't bypass your alcoholism without consent. Now, dilated thick cardiomyopathy. You know, these pictures always make me hungry. I just keep thinking what that would be doing with a little vinegar, breaded up, fried maybe a little bit. Tasty. Now, that is a big dilated chamber. That's what we meant by left ventricular end systolic diameter. At the end of systole, how much can it empty? The end of systole, how much can it empty? The end of systole, how much can it empty? The wall has become thin as the chamber dilates. The wall has become thin as the chamber dilates. The wall has become thin as the chamber dilates. So, subendocardial fibrosis. Subendocardial fibrosis means the walls become thin as the chamber dilates. And it can become fibrotic as well. It just means it doesn't contract so well. This is a picture of congestive failure. That's extravasculature. That's congestive failure, and that's extravasculature. It looks similar to the picture we did under congestive failure. You know why it looks similar to the picture we did in congestive failure? Because it's the same picture. That's why it looks similar. Oh, you know why it's the same picture? It's the same disease. We do it twice, though, because it's such an important disease. Okay. Look at that. Oh, let me see those spins again. Let's try those again. Wow. Let's do that again for the spin. Congestion. Whoa, what's that? Hey, where are the pulmonary arteries? There they are. Is that a heart big? Oh, your heart is so big. Oh, there's more room in a broken heart. Ah, Carly Simon. There it is. It's hip to be miserable when you're young and intellectual. Okay. Oh, look at those pulmonary arteries. Yes, there they are. Huge, aren't they? Yep, that's it. This person needs a diuretic. They need an ACE inhibitor. They need a beta blocker. But they need ACE and beta blocker and spironolactone more because they lower mortality. ACE, beta, ACE, beta, ACE, beta, spironolactone. So what is the difference between a Chagas disease, Adriamycin, post-myocarditis, viral cardiomyopathy, and coronary disease one? Aspirin and the ability to do bypass. Remember, it's better to be having ischemic disease. You can do more to fix it. Hypertrophic obstructive cardiomyopathy. What is the most common presentation? It's not sudden death. The most common presentation is regular old-fashioned shortness of breath. Oh, well, that's not very exciting. Regular old-fashioned shortness of breath. That's not very exciting. I know. Ready? It's much more dramatic to say, reporting to you today from Madison Square Garden. Dribble, 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 shoot, score, die. Well, it's a lot more dramatic than saying, reporting to you from the Staples Arena. A man became short of breath while running today. Wow, selection bias. It's selection bias. Sudden death seems to be the most common, but it's not. It's, remember, hypertrophic obstructive cardiomyopathy, genetic. Hypertrophic obstructive, genetic. Hypertrophic cardiomyopathy, hypertension. Remember, you get hypertrophic and it makes you short of breath. Short of breath. When you have beta agonists in tachycardia, the ventricular chamber size gets smaller. See, this is the ventricle trying to empty. This is the extra hypertrophic piece of meat on the side of that ventricle. Asymmetric septal hypertrophy, the extra hypertrophic piece of meat on the side of that ventricle. Anything that makes the chamber smaller. Anything that makes the chamber smaller increases the obstruction. Chamber bigger decreases the obstruction. Digoxin empties more. Beta agonists go faster, empties more. Tachycardia. When does the ventricle fill? The ventricle fills during diastole. So you don't have enough time to fit. You don't have enough time to fit. You don't have enough time to fit. Tachycardia, I don't have enough time to fill the heart. All of these things here, every one of them, is a way of saying, can you list the things that cause the left ventricular chamber size to decrease in size? Tachycardia, decreased ventricular filling time. Beta agonists, increased emptying. Dehydration, hypovolemia, exercise, tachycardia, they're all saying empty left ventricle increases obstruction. Makes it worse. Puts me in a hearse. Oh, look at that. The number one thing for shortness of breath. The number one clinical manifestation is shortness of breath. You can get chest pain and syncope, and sudden death is the least common thing. Hey, why do we get an S4? We get an S4 because we have left ventricular hypertrophy. Get an S4. You see, when it says sudden death can be the first manifestation, it's definitely your last if you have it. But the thing is, can be does not mean the same thing as most common. Can be your first manifestation does not mean most common. All patients with hypertrophic cardiomyopathy will have left ventricular hypertrophy on the EKG. But the most accurate thing is the echo, showing the hypertrophy and the alteration in valve function. When you have hypertrophy like that, it actually pulls your mitral valve leaflet, sucks it up out of the way in the wrong way. That's what we mean by systolic anterior motion. In systole, the valve leaflet in the mitral valve gets pushed out of the way. Systolic anterior motion, SAM. Systolic anterior motion, or SAM. The treatment is beta blockers and other negative inotropes and things that slow the heart. If you have a negative inotrope, it decreases emptying. If you slow the heart rate, you increase filling. Let's go back to that slide that looked at what happens here. See these things? If you say the opposite, it's the treatments. If beta agonists precipitates it, beta blockers make it better. If tachycardia precipitates, bradycardia makes it better. If Valsalva or standing makes it worse, That means leg raise and squatting make it better. So that means that people with hypertrophic obstructive cardiomyopathy slow the heart rate. Disopyramide, what is that? Disopyramide is like an 8-track tape player or a black and white television. Is it still around? Yes. What do you think about people who would use an 8-track tape player? Well, you'd say, where have you been for the last 25 years? Disopyramide. Disopyramide is a class 1A antiarrhythmic. It's in the same class as quinidine and procainamide. But disopyramide is extremely negatively inotropic. It's very negatively inotropic. It's so negatively inotropic that it increases ventricular filling. Disopyramide. Restrictive cardiomyopathy, what do I need to know? I need to know that restrictive cardiomyopathy is something that is uncommon because sarcoid, uncommon. Amyloid, uncommon. Hemochromatosis, uncommon. Cancer and fibrosis, uncommon. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Yes, these are the things that make it so your ventricle doesn't contract, doesn't relax. It just lies there. Oil can. Oil can. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. What is it they call? They didn't do this in your medical school? They didn't do this in your medical school? Restrictive cardiomyopathy. Basically, you have walls that don't move. And that's all you have to know. Give them a diuretic and treat the underlying cause. Cardiomyopathies, clinical manifestations, what do they all have in common? They all make you short of breath. I'm shocked. They all give you dyspnea on exertion. They all make it so that you have S4. And you see how it's combined here with S3? That means restrictive cardiomyopathy is both systolic and diastolic dysfunction combined, if you think about it. What's that Kussmaul's sign? What happens to your neck veins when you inhale? What happens to your neck veins when you inhale? You can't feel it. Come on, inhale. What happens to your neck veins? Normally, neck veins should go down. When you inhale, neck veins should go down because it should pull fluid into the heart. Normally, neck veins should go down because it pulls blood into the heart. But Kussmaul's sign is an increase in jugular venous pressure on inhalation. It's an increase in jugular venous pressure on inhalation. It's an increase in jugular venous pressure on inhalation. Okay? So therefore, Kussmaul's sign is seen in two major things. Number one, restrictive cardiomyopathy. Number two, constrictive pericarditis. Restrictive cardiomyopathy, the heart should not move. I breathe in and the neck veins go up. Constrictive pericarditis, and you breathe in and the heart can't fill. The neck veins go up in all of them. The neck veins go up in all of them. The diagnosis, like all cardiomyopathies, X-rays show congestion. Do you see how nonspecific that is? By the way, I don't know if you noticed or not, but these slides that you see here, the point of us showing them is to show you that every X-ray that we've said for every valvular disease, with the exception of mitral valve prolapse, shows a heart size that change and pulmonary congestion. Nonspecific. Nonspecific. All of them. But you do get an echo that shows a myocardium that doesn't move. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. No good treatment. That means treat the underlying disease because you can't do anything for it in general. So pericardial disease. What's the difference between pericardial disease and these? Pericarditis. What causes acute pericarditis? Well, acute pericarditis is caused by any form of infection. So pericarditis can be caused by any form of infection. Pericarditis can be caused by infection. What infection? Any infection, but viral is the most common. What infection? Any infection, but viral is the most common. What connective tissue disorder? Any connective tissue disorder, but lupus is the most common. What trauma? Any chest wall trauma, but chest wall trauma is the most common. So what causes pericarditis? Anything that inflames, infects, irritates, or annoys the pericardium. That means any form of connective tissue, any form of cancer or trauma, as long as it affects the heart. Now, pericarditis is a functional disease. It has a problem with pain that is both positional and pleuritic. Pain that changes with bodily position and pain that changes with respirations. It is both positional and pleuritic in nature. It is both positional and pleuritic in nature. Chest pain that is both positional and pleuritic in nature. It has a functional test. It has a functional test which is an EKG. The EKG shows ST segment elevation everywhere, but what is the most specific thing? Only with pericarditis and nothing else is PR segment depression. PR segment depression is unique and nothing else. It is a functional disease. Now, you see the sign where it says here, absence of reciprocal leads? When you have a myocardial infarction with ST segment elevation in one place, you usually have depression in another. If it's raining in one place, it's arid in another. If you have ST elevation in the anterior, the inferior usually shows depression. Reciprocal leads means if you're up in one place, you're down in another. So pericarditis is ST segment elevation everywhere. There's no depression anywhere. Pericarditis is a functional disease with a functional presentation. Chest pain that's positional and pleuritic. 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 You have a functional test in EKG. You have a functional treatment, non-steroidals, as well as treating the underlying etiology. A man comes with pericarditis and he's been put on non-steroidals for the last 5 days, 4 days, 3 days. He still has sharp pleuritic pain. And let's say they even tell you that he's rubbing on you. Non-steroidals, not better. Next best step in management? Steroids, steroids. Well, what's the difference between pericarditis and pericardial tamponade, exudate, transudate? Look at that. Looks like regular medical school. Woo-wee! Don't call me till you tamponade. Well, why is we drinking lemonade and treating tamponade? Well, I don't know. Maybe we should drink lemonade and treat tamponade. You see all these things, transudate, exudate, serosanguinous, frank blood. Frank blood, that must be like a mafia guy. Frank blood. It's like Vinny the Chin. Frank blood, I like that. Okay, I don't know what any kind of other blood there is, frank blood. I mean, that means a lot of blood. A lot of blood. Well, you know, if you look at these things here, you know what they are? Any cancer, trauma, infection, connective tissue disorder. If you look at this list, just like regular medical school here, what you'll see is it's coming out to exactly the same things that cause pericarditis. Wow, you mean that whole slide there of injury? I like that, injury. That's what we used to call trauma, but now we're calling it injury, just to confuse you. Almost lost you around the corner there, didn't we? Okay, so this is what they do to you in regular medical school. They say injury on one slide, trauma on the other, irritation on the third, annoyance on the other. Okay, don't talk to me and I'll get a pericardial tamponade. Saying the same things. All the things that can cause you to have any infection, any connective tissue disorder. They all can cause slow fluid accumulation. If it's slow fluid accumulation, the pericardium will stretch. In other words, if I put in 5 cc's today and 5 cc's tomorrow and 10 cc's the day after that, do you know that the pericardium can stretch to be 2 liters? I can get a 2-liter pericardium. It'll slowly stretch and accumulate. Now, if that fluid accumulates rapidly, If that fluid accumulates too rapidly, what ends up happening if it ends up rapidly is that, well, you go slow, you can get liters into that pericardium. You go too fast, and you can get tamponade. You know what it is? 2 liters slow will keep you asymptomatic. 100 milliliters fast is fatal. Fatal. 10 milliliters injected today, I can go 10 milliliters every day or two. For months, no problem. However, 50 milliliters injected fast is fatal. What is the difference in tamponade? Between these others, you get tachycardia. Well, they all give you tachycardia. Distended neck veins, hypotension, and clear lungs. Well, what's the difference between that and a person with a pulmonary embolus? The chest is clear on physical examination in a person with both pulmonary embolus and tamponade. So how are you going to tell that that's not a person who has a pulmonary embolus? Pulmonary emboli would not give jugular venous distension. Pulmonary emboli would not give jugular venous distension. Pulmonary emboli would not give jugular venous distension. Pulmonary emboli would not give JVD. Tachycardia, hypotension, distended neck veins. 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 Tamponade. Well, next thing you know, the guy's got an effusion, lowering his blood pressure, causing him confusion. Said, hey there, you got a needle for me? Puts it under the xiphoid and fluid I see. Emergency pericardiocentesis. Extravasating fluid. 100 ml, save life. Next thing you know, the guy's got a window. Draining out fluid. Into the pleural space it does go. It doesn't accumulate anymore, no tamponade, do you see? He's walking out the door with his family. Successfully treated pericardial effusion, that is. Needle pericardiocentesis followed by a window. Yeehaw! Diagnosis. The diagnosis. Well, let's see. What do you see on an EKG that's unique? You see small complexes alternating with big complexes and small complexes alternating with big complexes. That's called electrical alternans. The heart flops forward and backward and forward and backward and forward and backward in the chest. Respiratory alteration makes the complexes not like the rest. I'm far away, I'm feeling very small. I'm getting closer, I'm feeling very tall. Oh. You know, I've been teaching this for 15 years and I never did that before today. I find you inspiring. See that? For all the knowledge and grandeur and beauty of the universe, the world is only as large as what is encompassed by our own minds. Huh? So there we have it. What do you see on an echo? Oh, you see fluid. Oh, my mother could say you see fluid. It's true, but my mother's the chief of cardiology at Columbia University. What's the earliest finding of tamponade? You see collapse. Collapse of the right atrium and the right ventricle. Diastolic collapse of the right atrium and the right ventricle. Diastolic collapse. The best initial therapy is a needle. EKG shows electrical alternans. What's the difference between this and the other things? Pulsus paradoxus. A pulsus paradoxus is a greater than 10 millimeter of mercury decrease in blood pressure on inhalation. It's a greater than 10 millimeter of mercury decrease of blood pressure on inhalation. When you breathe in, what happens to your blood pressure? Decreases, but it doesn't decrease more than 10 millimeters. Echocardiogram, the pericardial fluid, the effusion. Look at this. Echo-free pericardial space between the da-da-da. That's saying effusion. See this whole sentence? Echo-free pericardial space between posterior pericardium, posterior left ventricular. I put that in there just so you would understand that that is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 words to say fluid. Fluid. Huh. Large effusion, heart may swing freely. I like that. Swinging on a Sunday afternoon. Fluid accumulating inside of you. And that means swinging freely is electrical alternans. Electrical alternans. The treatment. Wow, water bottle heart, I like that. Okay, but the treatment is to aspirate the fluid accumulate, treat the underlying etiology, and to remove it with a window. What is the difference between these things and tamponade? Tamponade is a super emergency. Why? You're going to die of hypotension. Tamponade is a super emergency. Why? Because a rapidly accumulating fluid and an extra 20 milliliters could be the difference between life and death. Tamponade, all the same things. Look at that. You see this list? Cancers, infection, no way. That's everything we just said. Any cancer, any infection, any trauma that's near the heart. Yes, it's the same things that we said before. Now, tamponade gives you hypotension, shortness of breath, and tiredness. A pulsus paradoxus is a greater than 10 millimeter of mercury decrease in blood pressure on inhalation. Now, neck vein distension with clear lungs. Neck vein distension with clear lungs is something that could be with a tension pneumothorax, but you would have to be told decreased breath sounds on one side. Shock just means hypotension. Decreased or muffled heart sounds means that the fluid is encapsulating the heart, so I can't hear it. It's acting like fiberglass inhalation. So decreased or muffled heart sounds simply means that the heart's encased with fluid. I can't hear it. I can't hear you. Why? Because I'm covered up. I can't hear you. Why? Because I'm covered up. Muffled heart sounds. That means I'm deaf or you're fat. It means you have fluid around the heart or you got a barrel chest and COPD. Muffled heart sounds is non-specific, but pulsus paradoxus is specific. Neck vein distension with clear lungs is specific. So therefore, what is going to be different about tamponade from many of the other things? Tachycardia and hypotension is everything under the sun. But tachycardia, hypotension, and distended neck veins is not. That could be pulmonary edema, but pulmonary edema does not give you clear lungs. And none of the others are going to give you a pulsus paradoxus. You need a systolic blood pressure of 90 to feel that radial pulse. If you inhale, the blood pressure can go into the 70s. Your pulse is gone. Your pulse came back. Your pulse is gone. Your pulse came back. How paradoxical. You inhale and your pulse goes away. You exhale and it comes back. You lost your pulse, but you're still alive. My, how paradoxical. Wow. How exciting. Well, the paradox of pulsus paradoxus, as we said, is that you inhale and you lose your pulse. A systolic blood pressure that's now gone below 90, losing the pulse. Kind of like me losing my hair. 1 minute it's there and poof, the next it's gone. Well, the other thing about tamponade is that this is a super emergency. Hypotension, tachycardia, distended neck veins, pulsus paradoxus, a needle pericardiocentesis. A needle pericardiocentesis. And when you have that needle pericardiocentesis, removing as much as 50 or 100 mLs can be life-saving. You take the needle out and it reaccumulates. Put the needle back in, you take out some more. You take the needle out and it reaccumulates. Put the needle in, you take out some more. Chronically, you cut a slice out of the pericardium called a window. Lets that effusion drain out chronically. Now, constrictive pericarditis is almost exclusively something that is chronic, that causes fibrosis, some chronic infection or fibrosis that allows the pericardium to become a thick, non-compliant calcific box. When you have a thick, non-compliant calcific box, in constrictive pericarditis, a thick, non-compliant calcific box in constrictive pericarditis, the heart can't expand, it hits the walls, it can't expand. Knock. The heart is expanding, it hits the wall, knock, pericardial knock. Well, when you have constrictive pericarditis, you start to get things like shortness of breath. Well, that's very nonspecific. See that shortness of breath on exertion? Very nonspecific. Anything gives you shortness of breath on exertion. Anemia, congestive failure. Orthopnea, positional. It can be congestive failure. Signs and symptoms, SS, that's signs and symptoms of right heart failure. The right heart fails. Big neck veins, big liver, big spleen, big hemorrhoids, big ascites, big edema. That's any sort of right heart-sided heart failure. Big liver, big spleen, big edema, big ascites. Kussmaul's sign. What happens to your neck veins when you inhale? Normally, you should have a decrease in jugular venous pressure when you inhale. Normally, you have a decrease in jugular venous pressure when you inhale. So Kussmaul's sign is an increase in jugular venous pressure when you inhale. The blood is coming into the heart. It can't get into the heart. Where's it going to go? Neck veins go up. Neck veins go up. Now, the heart fills, it can't fill. Knock. Constrictive pericarditis. Neck veins go up in inhalation. Kussmaul's sign. Now, the most accurate test for constrictive pericarditis is to do an echo or a chest x-ray or a CT or an MRI looking for the anatomic thickened calcified box called the pericardium. However, the thickened calcified box called the pericardium, before you get to the chest x-ray, the chest CT, and the MRI, you can tell from the knock, pang, and the Kussmaul's. Kussmaul's, knock, constrictive. Kussmaul's, knock, constrictive pericarditis. Kussmaul's, knock, constrictive pericarditis. Kussmaul's, knock, constrictive pericarditis. Kussmaul's, knock, constrictive pericarditis. How do you tell before you have the scans and the echo? Now, low voltage, you notice how nonspecific that is? Tamponade, obesity, small complexes, very nonspecific. Anything, obesity, large breastedness, barrel chestedness, low voltage, too nonspecific. Chest x-ray can be normal. The chest x-ray can also show the calcifications. This thickened or calcified pericardium on a CT and MRI is the most accurate diagnostic tests. It looks just like restrictive cardiomyopathy, except in restrictive cardiomyopathy, the heart does not move on echo, and the chest x-ray and chest CT show a normal pericardium. The chest x-ray and chest CT shows a normal pericardium on restrictive cardiomyopathy. Well, what is the medical therapy to thicken, thin down my pericardium? There isn't any. You got to remove it. So the only way is to get rid of it. You give diuretics to empty out the heart, but the only way to do it is to get rid of the pericardium. The only way ultimately to fix constrictive pericarditis is to remove it. Now, constrictive pericarditis is a surgical disease, an anatomic disease. Kussmaul's, knock, constrictive. Anatomic tests, anatomic treatments. Constrictive pericarditis, very unusual. Most of you will never go and see a case in your entire lives. Calcified fibrotic box called the pericardium. Tuberculosis, fibrosis, radiation. Restrictive cardiomyopathy, the heart does not move. Constrictive pericarditis, the heart moves until it hits the pericardium. Myocardial and pericardial diseases, we're now over. We'll go into our next section.